Good afternoon to all our participants. Welcome to today's webinar on COVID-19 antivirals. To help moderate today's lecture, may we call on Dr. Mark Pasayan, our infectious disease expert from the Philippine Health Network. Dr. Mark.
Good evening, everyone, and welcome again to tonight's webinar. The Polymed Health Network has been doing a lot of lecture series in the past months regarding COVID and some other conditions, and we are very fortunate to have with us again another infectious disease specialist, and to talk about this new drugs in the COVID-19 treatment pipeline. Now, the COVID-19 is a very dynamic disease, and every month there are new treatment and modalities that are being introduced, and we're still waiting for the further recommendations on this treatment regimen. And to give us a quick background on this new medications for COVID, we are very fortunate to have another infectious disease specialist. But to open this webinar, I'd like first to call our president and CEO of the Polymed Health Network, Mr. Jaime Jimmy Ismael. Sir, over to you.
Thank you, Dr. Pasayan, and good afternoon or good evening to everyone, to all of our participants in this webinar. Welcome to this continuing Polymed Health series, focusing on various matters, and COVID in particular, for today. And we're very fortunate to have with us today an infectious disease expert, Dr. Solante, in the person of Dr. Solante, who will give us the current views on various treatment options for ambulatory or outpatient COVID-19 patients, and one of them is Molnupiravir. And as we all know, COVID is here to stay, and it has mutated and will continue to mutate. And I think the current thinking out there right now is that this pandemic will eventually become an endemic, hopefully. And for that, we need to have all the possible treatment protocols in place. And it's good that the major pharmaceutical companies are racing against time to actually develop new treatment protocols other than vaccines, which have been the primary mode of preventing the infection. And hopefully, these new antivirals will give us another option, a very effective one, especially for the mild to moderate cases. So this is an exciting time for all of us, and we're also fortunate that we are given the opportunity to actually provide this new medicine, Molnupiravir, through a compassionate special permit that was granted to our 4 hospitals, Polymed Health Network, in San Jose, Del Monte, Santa Rosa, Tanawan, and Iloilo. Of course, through the help, through the initiation of MedEthics, a member of the AC Health Network, which will be importing about 300,000 doses of this medicine from Merck and Ridgebacks, Molnupiravir. And this is the first, again, oral antiviral medicine to be authorized for the treatment of mild to moderate COVID-19 infection. So it will soon be available. I believe within the month, the first shipment will come in. In fact, I think this Friday. So this is something that we can provide through our Polymed Health Network, of course, through a prescription. But Dr. Solante will talk about, in general, all of the medicines or antiviral medicines available out there, with a focus on Molnupiravir, given that it will be the first that has been given that permit on compassionate use. So again, thank you for participating in this evening's webinar, and please feel free to ask whatever questions you may have to Dr. Solante through Dr. Pasayan as we go through the presentation. Thank you and have a good evening.
Thank you, Sir Jimmy, for that. Before I proceed, I'd like to acknowledge first the presence of our Vice President for PSQM for Qualimed Health Network, Dr. Gina Nazareth. Okay, so now our speaker is Dr. Rontgene Solante. He is actually my good mentor and colleague from PSMID. He is a fellow. Sorry, he's a past president of the Philippine Society for Microbiology and Infectious Diseases. He's the head of the Adult Infectious Diseases and Tropical Medicine of the San Lazaro Hospital, the head of the Infection Control Committee of Manila Med and Adventist Med, and a member of the Board of Regents of the Philippine College of Physicians. Sir, good evening and welcome to QualiMed.
Hi, Mark. Good evening, and good evening also to Mr. Ismail. It's an honor to be sharing with you some updates on antivirals, and hopefully the information that we can get tonight can also help us benefit our patients later as we move on. And yes, as we always say, hopefully COVID will be endemic, and we'll just be treating like an influenza and mostly outpatient basis. So I'll start sharing my slide. Okay. So the focus for tonight's talk will really be on the antivirals, and that's really managing patients with COVID or confirmed COVID in the outpatient setting. And we know that for the past 2 years that we have been having this COVID-19, a lot of the treatment has been focused on the management of inpatient and hospitalized COVID, focusing more on prevention of death, prevention of complications, and the role of agents like corticosteroids, tocilizumab, baricitinib, including the antiviral IV preparation remdesivir, has never been so very important in our management. A lot of patients has been given this, and I think we save a lot also of lives. But as we look forward into the management of COVID, what we're really trying to point out now is that how can we prevent patients from admission to the hospital, which is very crucial in terms of health facility capability. And we saw that in the past 2 to 3 surge of COVID-19, that when we have cases, overwhelming number of cases, a lot of these patients, particularly those vulnerable population, cannot even find an emergency room that is vacant or a hospital that is can accommodate them to be treated. And here, if you look at the different stages and options of treatment options, it seemed logical now that there are treatment that can be given not in the hospital, but preventing these people or patients from going into the hospital. Because aside from vaccine, we know vaccine is the most important preventive modality or intervention, but there are also drugs that we need to have in order for those vulnerable population that still develop the symptoms even if they're vaccinated, stopping the viral replication and more or less preventing them from going into the moderate or even the severe form of the infection. So what is critical here is really the management of the mild to moderate disease. More than 70 to 80% of COVID cases, based on our data, the Department of Health, are in this particular group of patients, the mild to moderate. And only a few will really proceed to COVID critical or severe. But there are specific populations that we need to also prevent from getting severe because of the risk of mortality. And here you can see some of them, like patients with advanced age, those who are obese, with chronic comorbid conditions like hypertension, asthma, or the presence of diabetes. And all these comorbidities has really been associated with a higher or poor survival. Okay? And this is what we want to target when we look at antivirals as an important or can impact lives of this patient that will not go into severe form of infection. So as you have known, the first among these what we call monoclonal antibodies that was given an EUA by the Philippine Food and Drug Administration was the Ronapriv. Okay, so Ronapriv consists of combination of your monoclonal antibodies, casirivimab and mdivimab. And it is really intended to treat those patients with mild to moderate, starting at 12 years of age, or anybody who starts at 40 kilogram in weight, not requiring supplemental oxygen, and high risk of progressing to severe COVID-19. And I'll show you data on this monoclonal antibodies later. But first, I will tackle the antivirals, and this is your Molnupiravir. So in the landscape of the antivirals, I think there are already big companies who are embarking on this drug. Aside from Merck, which is the drug company that was able to produce Molnupiravir, there are also those with Pfizer and some with AstraZeneca. So Molnupiravir, this is the structure of the antiviral drug. Okay, so how does it cause inhibition of replication? It causes the virus to mutate. Okay, to the point that the enormous number of mutation can make error in terms of copies. So it prevents from further copying and further replication. Okay, and because of this type of mechanism of action, it is anticipated that it can have a very high barrier to resistance, and it has been proven in some preclinical data, so in non-human or in animal studies. Okay, so basically, because of this ability to cause a catastrophic mutation to the point that it will prevent mutation, then in a way that is how it will act in terms of inhibition of viral replication. Okay, so this is the active drug, the DN4 hydroxytidine, and this is the pathway by which the drug can act on the virus. It prevents further replication. And Molnupiravir, the parent drug, which is this one, the NHC, has also been proven to be effective for other infections or viral infections in the past, like Ebola, even influenza. And interest in terms of activity against COVID-19 has been drawn up by by the experience in the previous viruses. So the first among this trial is the move in and the move out. So this is the Molnupiravir inpatient and the Molnupiravir outpatient. So in the Molnupiravir inpatient is still ongoing. Okay, so this is given to patients who are hospitalized. Okay, and given this drug, and the endpoint of your move in is to assess how the drug can decrease the viral load among hospitalized patients and to prevent further progression to more severe form or critical COVID. But what is currently being floated upon by Merck is its highly successful move out trial. So this is the outpatient trial of Molnupiravir in non-hospitalized patients. Okay, so this is the fact that they are supposed to enroll 1,850 patients, but because of the impact that during the interim analysis and data of the trial using the Molnupiravir 800 milligram every 12 hours, by which it was able to attain a lower percentage of hospitalization or death by day 29 compared to placebo. Thus, it was given provisional EUA in some countries already for mild to moderate COVID. Okay, so this is the day 29 interim efficacy analysis of this Molnupiravir. So these are mostly patients at risk with mild to moderate clinical presentation, confirmed COVID, and were given in Molnupiravir 800 milligram every 12 hours and compared it with the other arm, which is the placebo. Okay, so they found out that among those in the Molnupiravir arm, only 7.3% were hospitalized. Okay, and 14.1% in the placebo. So it cut half the hospitalization rate that was seen among those who received the placebo. And what was very surprising to see that when they were given to the arm or to those who received the investigational product, which is Molnupiravir, among those who received it did not die. So even if they were hospitalized, the 7.3 they did not experience death, unlike in the placebo, where 8 of those died that were admitted. And why is this very important? Because these were given to participants whose risk of more severe form of COVID was very high. So these are patients who are obese, those with chronic medical conditions in the form of coronary artery disease, and those also who are elderly. Okay, and comparing the adverse event among those who receive molnupiravir compared to placebo, it's like more or less it's the same. So when you look at data like this, so meaning safety and tolerability is an important aspect in evaluating a drug like this, especially when taken outside or outpatient. Okay, so drug-related adverse events is more or less the same as that in patients who receive the placebo. So that means that this drug is safe and tolerable. And in the event that this drug was discontinued, only a few of them, only 1.3% of the molnupiravir arm discontinued the drug compared to 3.4% in the placebo. So with regards to its efficacy, not only clinically, but also it appears that it's also stable and active against any of the SARS-CoV-2 variants, particularly the Delta, which is now the dominant variant that is present in the Philippines. So due to this positive result, no, the Safety Monitoring Board of this trial was told the investigator to stop recruitment early and applied for EUA in some of the countries. And we know that there are already countries who has given an EUA for this molnupiravir. So this is how the performance of the drug in terms of comparing the different. So the part of this phase 2-3 data is the dose finding mechanism of the trial, by which they are looking which doses has been maximized and optimized to prevent the development of severe infection. And they found out that based on the ability of this drug to inhibit and lower the viral load, so undetectable SARS-CoV-2, it seemed that the 800 milligram demonstrated undetectable RNA in the nasopharyngeal swab from baseline through day 29, compared to the other doses, which is in the 400 and 200 milligram, and of course comparing that with placebo. So they also track all the changes in terms of how much viral load decreased from the time they started the treatment up to day 29. And there was a linear relationship in terms of a downtrend of the titer of the SARS-CoV-2 RNA virus among those who received the drug. And again, it seemed that consistent with the clinical improvement, there was also consistent decrease and faster change in the RNA viral load among those who received the high dose of 800 milligram twice a day. Okay, so this is also how they tested the drug against the different variants of concern, from the alpha, the beta, gamma, and delta, looking at the inhibitory concentration, 50% that will be inhibited by the drug, and all of these are very significant. And when you look at delta and beta, which are what we call poorly sensitive to the treatment, like it can affect your antibody production, and it has not affected significantly the ability of this antiviral drug to inhibit even these variants of concern. Another study that I would like to share with you is this study from Fisher et al. So if you look at some of these authors, these are well-known authors of HIV drug. Okay, so here they did a phase 2A double-blind, placebo-controlled, randomized, multi-center trial conducted in the United States, and a 1:1 allocation for those patients who were given 200 milligram of molnupiravir compared to the placebo, and a 3:1 allocation for those given 400 or 800 milligram and compared it with placebo. So during the interim data, out of the 200 participants that were enrolled, this was the result of the data. So this is a preprint. This has not yet been published. Just like the move in and the move out trial, it has not been published. But again, it seemed very promising that consistent with the mother trial, which is the move out trial, that molnupiravir 800 milligram was associated with a lower virus isolation. So meaning able to eradicate the virus and earlier clearance. Okay, so from 100% of those who received the molnupiravir compared to 11.1% only in the placebo. So this is vital in terms of when you are carrying the virus and when you have mild infection, early viral clearance is imperative for you to not to transmit the infection, and more importantly, will prevent also progression of the disease to more severe form. And they found out part of the endpoint here is the decreased time to viral clearance. So meaning earlier clearance of the SARS-CoV-2 was also seen among patients who were in the molnupiravir arm compared to placebo. So you'll have earlier days of less infectious and earlier days also of less symptoms. So you can have an earlier recovery. Okay, so they conclude that molnupiravir is the first oral direct-acting antiviral shown to be highly effective at reducing nasopharyngeal SARS-CoV-2 infectious virus and viral RNA, and has a favorable safety and tolerability profile. So if I'm going to share with you the table, the by which they compared the different doses of molnupiravir from 200 to 400 and then 800, and this is your placebo. Okay, so these are the baseline viral load of each of the treatment arm. So you have here the copies of your viral load, and then these are also the population by which each of the treatment arm has one risk factor, enrolled in their group. So the highest among this with more than at least one risk factor for severe disease is in the molnupiravir arm, 800 milligram, and then followed by the molnupiravir 400 and 200. So meaning most of those enrolled in this particular study are really are participants at high risk of developing severe disease. Okay. So they look at percentage of participants positive for infectious SARS-CoV-2 virus. So they measure the SARS-CoV-2 from day 1 to day 5 until day 29. And on day 1, these are the percentage of participants who are positive for the SARS-CoV-2. And on day 5, on the day that the treatment was the last day of the treatment, you'll notice that among the hosts, those who received the 800 milligram, zero isolate or positive for SARS-CoV-2 virus. Okay, and if you look at the time to SARS-CoV-2 viral RNA negativity, you have an early negativity with your molnupiravir 800 milligram BID, 14 days compared to the other treatment arm. Okay, and if you look at also the change of the SARS-CoV-2 viral load from baseline up to the end of the study, you have the highest decrease in the viral load in the molnupiravir 800 milligram BID. Okay, so although they were not able to come up with the endpoint of looking at the risk of hospitalization among these patients that were enrolled in each of this arm, but they said that the ability of the treatment to reduce and eliminate infectious SARS-CoV-2 is also an essential therapeutic endpoint that we should be considering when we treat patients as an outpatient, because these are parameters that when you reduce and eliminate the virus, then there's also, it follows that this patient will not proceed to severe form of the infection, and at the same time, less of this patient to be infectious. So it's important in terms of both transmission and prevention of progression to a severe disease. So here, they plotted the time to clearance among those patients who responded to this molnupiravir, and you look at this line. The green one is the dose that has highest time to clearance of the viral load in this particular trial. Now, in terms of the adverse event, okay, so it's really very minimal. Okay, in fact, adverse event reported by 5% of subjects in any group is in the form of dizziness and insomnia. Okay, so even in the high dose, you don't 0% in terms of dizziness, and only one patient complained of insomnia. Okay, so more or less, this is the safety profile that they are really banking on that it can be administered safely even in an outpatient setting. Now, the third data that I would like to present is this data coming from India. Okay, and this is a clinical study report submitted to their FDA in India. Okay, so here, this is a phase 3 prospective open label randomized multi-center study looking at the efficacy of Molnupiravir capsule plus standard of care versus standard of care alone without Molnupiravir in Indian patients with mild COVID. So they were able to enroll a total of 1,220 randomized to the investigational product, which is Molnupiravir, 610 of them, and then in the placebo plus the standard of care, 610. So this study was done in 19 sites in India using 200 milligram formulation of Molnupiravir. So 4 capsules of this, which is 800 milligram, and given twice a day for 5 days. Okay. So in the preliminary data, they found out that no patients were admitted in the hospital in the 28-day duration, both for the placebo and the Molnupiravir. So that's why they cannot calculate this as an endpoint. But if you look at also the other study endpoints, like clinical symptom improvement, which is very high in among those who received the Molnupiravir compared to placebo on day 5. That's why it's significant. Risk difference is very high. There's also a very the time to clinical improvement is also earlier, 10th day, compared to the placebo. And then the rate of RT-PCR negativity was also higher among those who received Molnupiravir compared to that of placebo, which is 81.5%. And in terms of the change in the SARS-CoV-2 viral load, you have a higher change in terms of decrease in the viral load in the Molnupiravir arm compared to the placebo. So remember, if you'll notice, even with placebo, there is also decrease in the viral load because as patients with mild symptoms, then there's also a time frame that on the 5th to 7th day, it will also decrease. But the impact here is in terms of the rapidity by which the viral load decrease compared to the placebo, and this will matter most among those patients who are high risk to develop severe disease, because a drastic change in the viral load, lowering the viral load, that means that you're safe. Your risk of getting the more severe form will be less compared to those whose viral load is slow to decrease. So this is how they compared in terms of the clinical improvement. So you have here the test tablet, which is Molnupiravir. So you'll notice that you have proportion of patients with clinical improvement higher compared to the placebo. So this is day 6, this is day 10, and then this is day 14. So again, consistent, no? But the impact here is that starting at day 6, there was already more than half of those who were given the Molnupiravir arm already manifest with clinical improvement starting at day 6, okay, compared to those in the placebo, and then continue to improve until day 10. The last study that I would like to share with you is another study. So you will be surprised, why are there so many studies that with Molnupiravir, when in fact only Merck only has the one study, the move in and the move out. Because in India, when this drug was when Merck made this drug available for the Indian companies, the Indian FDA required them also to make a parallel study in order for them to be approved as a requirement to be given an EUA. Okay, and that's the reason why that most of these Indian companies who are also who also partner with Merck also did their own study among Indian population. So this is the second study that also did by an Indian company. Okay, so you'll not be surprised that the tablets that will be available in the Philippines are coming from these Indian companies now. So here, this is a prospective randomized parallel multi-center phase 3 clinical trial, again, to assess the efficacy. And of course, part of that is the safety of Molnupiravir 800 milligram, and then compared to the standard of care, okay, on patients with mild COVID confirmed with an RT-PCR. So Here, they were able to recruit a total of 1,218 patients, and then randomized to receive molnupiravir, and the second group received the placebo. So currently, they were able to enroll 403 patients, and this is being presented in this interim report for this company to be given an EUA in India for the use of molnupiravir. So just like in the previous studies, the 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 endpoint are more or less the same. So it's looking at how important, no, how rapid symptoms will improve with molnupiravir. So again, here in day 5, you have in the 800 milligram, you have 79% of the population already have clinical symptom improvement, and on day 10, almost everyone already recovered, no, compared to the placebo, wherein only half of them have symptom improvement on day 5 and 82% on day 10. Time to clinical improvement really mattered a lot, and has been proven to, with compared with previous studies or previous to other studies, you have more rapid clinical improvement starting at 5 days in the molnupiravir arm, while in the placebo it will take 9 days. Okay. Rate of RT-PCR negativity at day 5 up to day 10, you have a higher negativity, and up to day 10, almost all of those who were positive are already negative. But even at day 5, 77% of the population were already negative, compared to those who received the placebo, in which only 50% are negative on day 5, and only 70% were fully negative on day 10. So that's a big discrepancy or difference, no, between those who receive a molnupiravir compared to placebo, and that's why it's clinically significant. And the rate of PCR negativity has also been correlated with the change in the viral load. So meaning the molnupiravir arm has the highest increase in terms of, or decrease in terms of the viral load compared to those who received the placebo. So in their analysis, molnupiravir plus standard of care compared to the standard of care arm alone, they notice faster clinical improvement, quicker RT-PCR negativity, and quicker viral load reduction. Okay, in terms of the adverse event, more or less, no, the adverse event is higher among those even in the placebo, and in fact, 3 of those adverse event, severe adverse events, were seen in the placebo arm compared to the molnupiravir arm, which is only 1. So all of the adverse events that were noticed in these studies resolved completely. So there was no adverse event that is considered life-threatening, and nobody died. Even in the previous trials, nobody died because of the adverse event related with the arm. So in summary, using molnupiravir 800 milligram BID for 5 days, so meaning within days or within 7 days of symptom onset, it has been proven that it can reduce risk of hospitalization or death. It has been able to reduce and eliminate the SARS-CoV-2 virus based on lower viral load, higher reduction of the viral load, and time to clearance is also shorter with the molnupiravir arm. And because of this viral kinetics, you also can correlate this that there was also faster clinical improvement, and it has been known to be generally safe and tolerable. And the other advantage here is it is an oral formulation. Okay, so for the Philippines, the EUA is under submission, so it's currently under evaluation. So we will wait for, hopefully within this weekend, we can see if the EUA will be released by the FDA for the approval of the use of this molnupiravir. So now I'm going to segue, no, the other group of what we call outpatient treatment of COVID, and this is with the use of your monoclonal antibodies. Okay, so currently there are 3 monoclonal antibodies that has been approved by the US FDA. Okay, so this is your bamlanivimab, etesivimab combination, and then your casirivimab, mdivimab, and then your sotrovimab. No? So all of these are monoclonal antibodies, and specifically the mechanism here is that it will block the spike protein interaction with the ACE2 that leads to inhibition of infection of host cells. So more or less, no, it has the same as mechanism as that with your vaccine, but this is fast acting. You don't need to wait for 2 weeks to develop an antibody. Once you will be given this, it will directly bind with your ACE2 receptor to protect the entry of your COVID virus. Okay. And at the same time, having dual monoclonal antibodies in combination represents a higher resistance barrier. So meaning the risk for resistance may be not common because you have a combination of two monoclonal antibodies. Okay. So you have here bamlanivimab in combination with your etesivimab, and then you have also here casirivimab and mdivimab. So they act on the separate epitopes of your spike protein, which is the part of the virus that will bind to the ACE2 receptor. Okay, so this is the history of the current status of these monoclonal antibodies, no, from November to September 2021. So you see, the development is really very fast, and most of these pharmaceutical are really looking into these monoclonal antibodies as one of the game changer that will prevent hospitalization and risk of death among patients with COVID-19. So the niche of these monoclonal antibodies is really more on the management of non-hospitalized patients, just like your Molnupiravir. With Molnupiravir, you have to give it within 7 days from the onset of symptoms. So you will have that opportunity that when you give it, timing is very important. Just like also with your monoclonal antibodies, timing is also very important, that within 10 days of symptom onset, you need to give this, no? So that this is where the viral phase of the stage of the infection, you'll be able to catch that patient in that particular stage, and you will prevent them from going into the pneumonic phase of the infection. Okay. So here they were able to identify again the risk factors for COVID-19 progression to severe disease. Why this is very important, as we have mentioned also in the Molnupiravir, because these are the population that we anticipated that once they have mild COVID or even moderate COVID, their risk of progression to severe disease is very high. Okay, and we don't want these people to be infected with even with a mild or moderate COVID. No? So this is one area we can maximize the use of this outpatient treatment. And even if they are vaccinated, we know that vaccines may not be 100% effective, especially for this group of population. So these are the important candidates for this oral antiviral drugs and monoclonal antibodies. Okay, so the downside of these monoclonal antibodies compared to your Molnupiravir is that this is given through an IV. Okay, so there should be someone who will administer it, and it should be administered in a hospital, and it should be they should be monitored. Okay, so infusion may take up 1 hour plus 1 hour again post infusion observation for both the IV and the subcutaneous administration. So this is something that if we'll have this also, or I think we already have like this, no, and it will really entail admission or observation in the hospital, unlike the oral formulation. So currently, these three drugs or monoclonal antibodies has been approved in the US and in some other countries now, no, in Europe, okay, and in the Philippines, the casirivimab and mdivimab has already been approved, and it's also now available in the treatment of non-hospitalized patients starting from age 12 years old and above who manifest with mild to moderate COVID-19 and who are at risk for progressing to severe disease. Okay, so these are the respective dosage and route of administration. So I'll just go each one of the efficacy data of each of these monoclonal antibodies now. So here they look at the first data that was released was the bamlanivimab monotherapy in combination versus that in combination with your etesivimab. No? So they found out that the monotherapy is less effective compared to the combination, especially in the treatment emergent BAM resistant variants. No? So that's why when you look at the combination, it's more valuable. And that's why I think in the US, they withdrew now the availability of your monotherapy, and they now recommend the use of the combination. Okay. So in the other monoclonal antibody data, They look at casirivimab and mdivimab. They gave it to outpatient treatment. So these are patients high risk for progression and given this drug, okay? And they found out that it significantly reduces hospitalization and all-cause death. So look at the 70% relative reduction of hospitalization. That's quite a lot, no, compared to just a placebo. So what's the advantage of these monoclonal antibodies? Okay, symptoms resolve sooner, more rapid viral load reduction, just like your Molnupiravir, fewer severe adverse event, and shorter hospitalization. So in those who were hospitalized, it was also, they shortened the number of days of hospitalization based on the fact that this is a monoclonal antibodies and it blocked also the replication of the COVID virus. And then when they look at also those who were admitted, okay, in the recovery trial, who were given, so these are patients who were admitted in the hospital, so hospitalized COVID, and were given also casirivimab and mdivimab. And they found out that among those who were admitted and given these monoclonal antibodies, okay, particularly among those who did not have exposure yet of COVID-19, there was an associated shorter duration of hospital stay, 13 days versus that of 17 days. So meaning this drug can be an important regimen also that can be given in hospitalized COVID. There were greater proportion who were discharged alive by day 28, and there was reduction of risk of progressing to invasive mechanical ventilation or death among 30% who received the monoclonal antibodies compared to those who did not receive it, which is 37%. Okay, so this is one also indication for the drug. No, but I think the most important utility of casirivimab and mdivimab is really in the outpatient setting. Okay, the third among this is your sotrivimab. Okay, so this is another monoclonal antibodies. Okay, and in this particular data, where they enrolled patients at higher risk for more severe form of COVID, when given this drug, there was reduced hospitalization and all-cause death. Okay, so there were fewer emergency department visit, and then AEs also were similar between groups and that of the placebo. So more or less, no, what we are after here is the 79% relative reduction in terms of hospitalization and possible all cause of death. No? So these are important outcomes that we're looking forward that when we will have these drugs, a group of population, vulnerable population will really benefit. So there are also approvals now in the US that this drug can also be given as prophylaxis. Okay, so for those who are exposed to COVID confirmed and are not fully vaccinated, or even if they are fully vaccinated, but they were exposed to a confirmed case, the US FDA has already approved the use of these monoclonal antibodies as part of an post-exposure prophylaxis to prevent the development of onset of symptoms among high-risk individual. Okay, so here in this data, when this casirivimab and mdivimab were given to household who were exposed to known COVID positive, okay, there was 66% relative risk reduction in the overall symptomatic and asymptomatic infection. Okay, and among those who developed symptom, the median time to symptom resolution was 2 weeks shorter than the placebo. Okay, because they found out that because of the monoclonal antibodies, there was a very high reduction in the viral load. Okay, so here the endpoint of being symptomatic, you decrease the risk of being symptomatic in 81% among those who received the drug that were exposed to a known COVID positive. Okay, and then of course this drug also bamlanivimab was also done among those in the nursing and assisted living facilities. So we know that these are individuals at high risk of moderate or even severe COVID. Okay, so you'll notice that with these monoclonal antibodies, it reduces also the ability to proceed to moderate symptom or to worsen, and more or less has an impact in terms of mortality. Okay, So the other important question, and we always have this question, if these antiviral drugs, if these monoclonal antibodies are also active against the what we call variants of concern, because we know that with the variants of concern, these are mutations that can also reduce the sensitivity of antibodies that being produced by vaccine, and including antibodies or antibodies of these monoclonal antibodies. And so if you look at these different monoclonal antibodies, it seems that all of these monoclonal antibodies are active against most of these variants of concern. And I'm focusing on the Delta variant again, because this is the variant that has the highest rate of transmissibility, highest rate of progression to severe disease, hospitalization, and including ability to affect and reduce the efficacy and effectiveness of some of this vaccine. So here, it seems that all of these monoclonal antibodies are active, okay, against any of these variants of concern, particularly the Delta variant. Okay, so my last slide will be on another monoclonal antibodies. No, this is produced by Astra. No, so this is AZD7442. Okay, combination of two monoclonal antibodies, long acting. Okay, and again, as just like what other monoclonal antibodies been done, reduce the risk also of progression to a more severe form of COVID. Okay, so in the preliminary data reported in this PROVENT trial, okay, as a pre-exposure prophylaxis, okay, with the endpoint of a SARS-CoV-2 RT-PCR positive among those symptomatic illness. Okay, so they were able to enroll 3,460 patients in the treatment arm, and in the placebo, 1,737. So this is a 2:1 randomization. Okay, and here in this preliminary analysis, it demonstrated significant protection against symptomatic COVID. No? So among those who received the drug, only 8, okay, had symptomatic illness, okay, compared to the placebo, which is 17. Okay, so computation of a risk reduction or relative risk reduction is 77%. So that means it is significant. So hopefully this drug will also be available, and there can be an added drug, no, that can also address outpatient treatment of COVID-19. In terms of the adverse event, more or less same as that with the placebo. So there was no COVID-related death documented in the treatment arm compared to the placebo. So here in this study, part of the adverse event was monitoring those who were infected and given the drug. And in fact, in the placebo, one developed severe critical and died. Okay, so this is the downside of a trial when you receive the placebo, and when you progress from mild to moderate and severe, then your risk also of death is there. Okay, so what is the outlook of treatment of COVID? Okay, so before we focus on treating patients in the hospital with the use of anti-inflammatory agents, with the use of antiviral drugs and immunomodulators. No? So the way I see it is that we now have a drug, or we now have an intervention that will prevent us from getting the infection in the form of vaccine, and that's what we want to happen. No? The herd immunity. Okay, but we said that vaccine is not 100% effective. So there will be some people that even if they're vaccinated, they can still develop COVID and can proceed to severe infection, or worse, those unvaccinated. So we don't want that to happen. So there is now available prophylactic agents in the form of antivirals and monoclonal antibodies. And the same as that when they will be symptomatic, these antivirals and monoclonal antibodies will prevent these people from developing a more severe form of COVID and entry into the pulmonary phase and the late pulmonary phase. And at this point in time, we already have drugs that will address also the pulmonary phase of COVID-19. So while these drugs are not yet available, but soon to be available, we need to protect ourselves. We need to maintain the health protocol. and we need to vaccinate as many people as we can in order to prevent more diseases, more surge of infection, and hopefully once these antiviral drugs, once these monoclonal antibodies are readily available, then hopefully we can address all avenues or aspects of the stages of COVID, which will really benefit our patients. Thank you very much for your kind attention.
Thank you, Dr. Solante, for that very informative talk on the new medications for COVID-19. Being the moderator, I think it's my privilege to throw in the first question. Sir, regarding the monoclonal antibodies, any precautions that we need to remember when we're giving monoclonal antibodies to special populations like the pregnant women and the immunocompromised?
Yeah, so I think as long as they're not contraindicated, so they're not contraindicated in this population. And I think the special precaution that we need to really monitor is in the data in the trial is the infusion-related reaction. Okay, there are those who had vomiting, there are those who had dizziness, and so most of the adverse reaction is infusion-related, and that's the reason why when infusing this to patients or candidate patients, they should be monitored in the hospital. They should be before they will be sent home. They have to be given some advices that if something they feel something unusual, they have to also give the feedback to the attending physician or to the hospital. So they are relatively safe and no major any adverse event related with these monoclonal antibodies.
Okay, sir. Thank you for that. We have a long list of questions in the chat box. Let me start with this first question. Actually, this is my question when you were discussing Molnupiravir, and since we have a lot of nephrologists in the room, what's the renal dose adjustment, sir, for Molnupiravir? Also, the hepatic dose adjustment, given that based from your talk, 800 milligrams twice a day seems to be the most promising. Are there some adjustment that we need to make if we have some, let's say, CKD patients?
Yeah, so far, no, we don't have yet information on dose adjustment for those with CKD and liver problem, no, at this point in time. Okay, but personally, I don't think there will be problems in terms of adjusting the dosage. Now, why? Because this drug is only given 5 days. Okay, and 5 days may not be as significant as that when you are looking at drugs that can be compared to drugs that will be given to more than 5 days. No, but if you look at the data, also there were dose escalating data. The nearest that the 800 milligram has the same efficacy is the 400 milligram BID. No? So probably if this will be approved by the EUA by given an EUA, so the pharmaceutical drug company that applies for this will also be giving an information if there will be adjustment of the dosage, particularly for those who are with renal problems and for those with hepatic problems.
Hapon. Kasi ito yung first time niya ulit.
Mark, naka-mute ka.
Sorry, sir. There's a question here, sir, by Dr. Aban regarding prophylaxis. I think this is about Molnupiravir. Can we use, when we say prophylaxis, I think the better question here, can we use this as post-exposure prophylaxis, the Molnupiravir?
There was no data on the post-exposure prophylaxis, no? All of the trial are done among patients with SARS-CoV-2 positive and with mild symptoms and at high risk for what we call severe disease. So there was no data on a post-exposure prophylaxis.
And I'm sure there's no data for pre-exposure prophylaxis.
Yes,
I think it's very difficult to use this as a pre-exposure prophylaxis. We have a question from Dr. Lilibet Maravilla, our medical director in Qualimed Santa Rosa. Meron daw, sir, bang subgroup analysis on those patients who had completed vaccination prior to contracting COVID? This is for the Molnupiravir studies that you presented.
Okay, so there was no data, not no other data was presented except the one that I have shown to you. No, so we don't know yet on how those subpopulation data or sub-analysis will factor in. No? But again, I think the important aspect here is that if we're looking at if those who were vaccinated and still develop COVID, in terms of are they more the patient that will respond more to, based on that rationale, probably they will, no? Because they already have an antibody, and if they will still be infected and they will have mild symptoms, then they can really benefit with these antiviral drugs.
Yeah. And how about, sir, the drug-drug interactions? In the studies kasi, di ba, they also included the standards of care, and I would assume that includes dexamethasone or enoxaparin. But are there any drug-drug interactions that they saw with molnupiravir, also with medications that their patients are using for chronic medical conditions like diabetes or hypertension?
Yeah. So in the phase 1 and phase 2, which is more on the pharmacokinetic of the drug, okay, there were none of the drug interactions that, or potential drug interactions that were seen in this molnupiravir. No, I would just like to mention here that in the Indian trial, of the 2 Indian trial, the standard of care was the use of ivermectin. Okay. So that's the only drug that was used, the ivermectin. There were no steroids given. So I forgot there was an herbal medication. So I think India loves to give also herbal. So molnupiravir plus ivermectin and supportive care compared with
Placebo.
Placebo, which is placebo plus ivermectin and the other drugs. No, so it's something like that. So
Okay.
the two arm has ivermectin part of their standard of care.
At least wala siyang interaction with ivermectin.
Yes.
No, sir. Ingat tayo dyan. Baka makakaroon ng idea. Anyway, so what if, there's a question, sir. What if the patient was given molnupiravir and the course became severe, unfortunately? Can we shift to remdesivir?
Yes. I think that's I think one of the things that we need to observe now. So when we're giving this drug, it doesn't mean that 100% you will not develop the severe infection. No?
Mhm.
But I think once that happened, then you need to recalibrate again your treatment. Now, remdesivir is another drug, no, that can also be given in the viral phase. Okay, and I think we've seen a lot of this in our experience, and I think there was one data that was published that giving remdesivir within 7 days might have an impact compared to giving it in the later part of the course of the infection. So yes, you can give remdesivir if you think the molnupiravir failed based on the appearance of the symptoms related with the patient's presentation.
Yeah, all these antivirals are very effective during the time that the patient is still viremic, and not when the patient is in storm already. And on that note, that's a question of Dr. Charlie Esteban. Can we still give it after 7 days of COVID infection, or if the patient is really very severe and came in early, sir? Still less than 5 days, but came in really very severe. Can we still give molnupiravir?
That we're waiting for the move-in trial, no? Because in the move-in trial, the population there are the hospitalized patients. Okay, so the objective of the move-in trial is that even if they will be hospitalized and you give molnupiravir, how will it impact in terms of lowering the viral load and not proceeding to a more severe and critical form? So I think that's a very good question, and hopefully we'll have the interim data also of the move-in trial, which is still ongoing.
Again, abangan natin ang mga susunod na kabanata. Marami pang pagbabago mangyayari. I'd like to ask this last question. This is from Ma'am Gaget Bengzon. In addition to the relative ease of administration, there is a significant cost saving when you're using Molnup versus your monoclonal antibody. Do you agree, sir?
Yes, it's a big disparity, and I think it's mainly because of its oral formulation, and I think other countries are really banking on that, and you just can't ignore why India is partnering with Merck, no? Because India has a very big population, and I think they want to maximize this antiviral drug having an oral formulation, which is really suitable for those in the countryside or those in the that cannot really afford given the cost also of the monoclonal antibodies.
Okay. With that, sir, again, would like to thank you for this lecture. Any last words, sir? We have a lot of attendees in the Zoom, and there are also other ID specialists in the Zoom. There's Dr. Elome de Vinagracia is also in the call. Sir, any last words for our audience?
Yeah, so the data that I have presented are still interim, no? So hopefully we can have the full data result, but I think there is already a submission in the Philippine FDA for this drug, and we know the result hopefully next week or before the end of the month, and we need this drug. Okay, we need drug that address outpatient COVID for them not to proceed into more severe form of infection. And I'm really hopeful, no, with this drug, it can really change the landscape in the management of COVID and help us ID clinicians and other practitioners in terms of the managing patients with severe COVID.
Okay. Yeah, I'm talking with Dr. Gina Nazareth, and since Ma'am Gaget Bengzon is sending message in the chat, ma'am, do you have any words to the Polymed Health Network? Over to you, ma'am.
Yeah, I just wanted to make all our doctors aware that we have applied for and secured CSP for this drug through our partners in AC Health, IE Medica, who are the exclusive importers of the drug. So that deliveries are already expected actually by the end of the week, and we can make this drug available through compassionate use application, as early as before the end of the month. So that's a benefit that the physicians of Polymed will have, that we can immediately make this drug available to our patients.
Ikaw palang unang makagamit niyan, Mark.
Very excited to use that, sir. Pati to Dr. Nazareth. Thank you, Ma'am Gaget, for that. And with that, I would like to close this webinar. But first, we'd like to give the certificate of appreciation to Dr. Rontgene Solante for showing his expertise and valuable role as speaker during this webinar entitled What We Need to Know About Molnupiravir and Other COVID-19 Antivirals, given on this 15th day of November 2021 via a Zoom virtual event. This is signed by the Vice President for PSQM of the Polymed Health Network, Dr. Maria Gina C. Nazareth, the Senior Vice President for Medical Affairs of the Polymed Health Network, Dr. Manuel Francisco Rojas, and our President and CEO, Mr. Jaime Ismael. Again, thank you everyone for attending. But before that, I'd like to plug our convention with Dr. Solante and Dr. Elome here and Dr. Reina Mendoza. We'd like to invite you to our 43rd annual convention, Recover and Rebuild, to know the latest updates on the COVID-19 infections and other infectious diseases. This will be on a virtual platform via Zoom and via our website, pisme.org.ph, on November 24 to 26. Ongoing na rin po ang pre-convention. It's happening every Saturday, November 6, 13, and 20. And we hope to see you all there as well. Again, thank you. And magandang gabi po sa inyong lahat. Mark Pasayan po ulit. Stay safe. And see you in our next PSQM Polymed Health lecture series.
Okay.
Thank you.
Thanks,
Thank you.
everyone. Bye.